Arthroscopic anterior shoulder stabilization is the most common treatment for shoulder dislocations. It's a keyhole operation that's usually carried out under regional anesthesia with the patient awake, or can be done with a general anesthetic. In most cases, this will be done as a day case procedure, so the patient should be in and out of hospital on the same day. If done under regional anesthesia, the anaesthetist will numb the arm with a nerve block, and we'll put a camera into the back of the shoulder to confirm the injury and any other associated injuries within the shoulder. We expect that the labrum would have detached from the socket, and so we'll need to complete that detachment, freshen up the surfaces, and pass sutures around the labrum to repair it back onto the shoulder socket. And the sutures are anchored into the bone with plastic anchors that are buried in and ideally stay in for life. We then stitch the wounds and put some small dressings on, and the patient's placed into a sling. The sling is usually kept on for 3 weeks, but we recommend early physiotherapy to start getting the elbow, wrist and hand moving, and to start some early safe shoulder movements. After 3 weeks, the sling is removed and physiotherapy is continued to regain the range of motion and then eventually strengthen the shoulder. And we recommend that heavy lifting and contact sport be avoided for 6 months after surgery. After 6 months, the patient can get back to a full level of activity. We usually expect that the patient's shoulder should feel better by about a year after surgery. The risks of an anterior stabilization include bleeding, but this is low risk with a keyhole operation. Risk of infection should be less than 1%, and risk of damaging nerves is low. There is a major nerve that passes underneath the shoulder, but we have to avoid that during surgery. There is a chance of persistence of instability, but the success rate with this operation is over 90%. There's a risk of recurrence or redislocation. This operation is meant to stop instability symptoms that happen with normal activities, such as raising your arm or putting your arm behind your head when you sleep. But it won't prevent a dislocation in the event of a major injury, such as a significant rugby tackle or a fall down the flight of stairs or a car accident. So there is a small risk of recurrence in the future. With any shoulder operation, there's a risk of stiffness. So we do want to get the shoulder moving again, but we have to balance that against protecting the repair. That's why we put you in a sling. And there will be some stiffness initially after the operation, but the physiotherapist will work on getting back the range of motion. There may be risks that are specific to you, and we'll discuss those in clinic prior to your operation.